Good evening, class. My name is Onyinyechi Nwanajuob, and I'm presenting today on medication reconciliation in primary care. These are my community members, and the topic I'm presenting on is medication reconciliation, as I stated, in primary care. So, give you a background and significance of this. Medication reconciliation is a systemic process. Well, this is the definition of creating and maintaining the most accurate and complete list of a patient's medications. These include prescription medications, over-the-counter medicines, vitamins, supplements, and herbs. And it compares the current list that we have, to a list that the patient would bring. And it basically makes sure that there are no discrepancies. It makes sure that the information that's being collected is accurate and safe for the patients to take. The primary purpose in primary care is really to prevent any errors and to improve the patient safety. My project aimed to improve the clinic that I worked with, their medication collection process, by introducing a standard toolkit. And the question that I posed, or that initiated this project, is will using a medication reconciliation toolkit reduce medication errors? I hope that through the course of this presentation and these slides that you will see for yourself that yes, using a standard medication reconciliation toolkit will and does prevent medication errors. According to the literature, and I reviewed a bunch, medication errors is the failure to properly account for prescribed or over-the-counter medications. Usually, if they're not accurately documented, it can result in harmful effects for the patients. These type of errors affect about 1 in 10 patients after they've been discharged from the hospital. The theoretical framework that guided this project is Null Appendix Health Promotion Model, and it really relates to medication. How it relates to medication reconciliation is it asks the question, explains why patients do or not engage in health behaviors. And a core health promotion behavior in primary care is maintaining an accurate medication list and taking medication safely as intended. The process of medication reconciliation is just not for documentation purposes. It's a behavior change, and it's also self-management. For the method and design, the Plan, Do, Study, Act PSDA cycle was used, allowing for testing of interventions and rapid feedbacks. The design is a pre and post intervention design. Basically, the outcomes were measured before and after a change was implemented. For the sample size, for the pre-intervention, we looked at 50 patients, which at the time, no medication reconciliation toolkit was used. And then post, intervention, we collected information from 42 people, it was also 50 people, but it was 42 people showed that they used it. The nurses used it consistently, and resulted in what I will explain further later. So the pre-intervention group were N equals 50, and the post-intervention group was N equals 42. For the sample size, there was an inclusion criteria and an exclusion criteria. For you to be included in this project, you had to be an adult between 19 and 65 years old and made an appointment within the time frame that coincided with my project. To be excluded from the project, you had to be younger than 18 years old or older than 65 years old. And this was just secondary to, collecting information. In older patients, some people are very forgetful. Younger patients, sometimes they don't even know what they're taking because they're pediatrics. So these were only adults. For the data analysis, the statistical analysis used was a z-test. I ran SPSS using the Maryville Provider Statistician. And this test that was used, the z-test, is used to compare proportions or means between two groups, especially when sample sizes are sufficient to justify the normal approximations. Going further into data analysis, so this was the information that I collected from in December, and this is the information that I used to obtain the results that I got. Lastly, with data analysis, pre-intervention results, without a standard medication reconciliation toolkit, 80% of errors were detected. For the post-intervention results, using the toolkit, no errors were detected. So these are the results, as I stated in a graphic way. As you can see in the pre-intervention results, there were 80% errors, and then in the post-intervention, there were no errors detected. So for the limitations, one of the biggest limitation that I had while working doing this project is time constraints during visits. One of the things that the nurses also complained of was that, one, they felt like they didn't have enough time to go through the information with the patients. This is a relatively small primary care clinic, but the patients that they see are chronic patients, and they're very sick patients. So the nurses, one of the things that they complained was that they felt like they needed more time to spend just collecting or reconciling medications. It's cumbersome, but once you start using it, they felt like it was a little easier for them. But prior to the introduction of the medication reconciliation toolkit, the nurses didn't have a standard way, so they just collected information without understanding or without trying to piece, the information together. Now, with the medication reconciliation toolkit, every aspect of the patient's medications needs to be addressed, which can be, detailed, which the nurses complained about as well. But they found that in the long run, or they found that with time, it became easier. Another limitation that I encountered was memory issues related to patient demographics. Excuse me, because these patients are elderly, and some of them are forgetful. But which is why we introduced, or the clinic manager and I talked about this, which is one of the reasons why we introduced the limitations or the exclusion criteria, because some chronic patients, when you're chronically ill, sometimes, secondary to medications, you could have some memory issues. So for the patients that we encountered memory issues with, we just excluded them from the project. Another thing the staff complained about were, just variability in staff training. One of the things I did for this project was to provide the same teaching, email information, flyer information across the board. But some nurses or staffers, sometimes they understand things differently. So a lot of reminders were sent, a lot of education was done, and a lot of making sure that the staffers remembered to use the form. Lastly, inconsistent workflows. Just the timing of the nurses and the staffers being at the clinic, Sometimes some nurses would say they couldn't find the information. There was just a bunch of, not excuses, but a bunch of variabilities. Some of the nurses there were some excuses and this, that, and the other. But understandably, what we had to do was to make sure that with each change in shift. So if it's a primary care clinic, so it's not a clinic it's not a hospital that runs day and night. Whenever there was a change in shift, we would make sure the clinic manager would make sure that she just reiterated that the medication toolkit should be used when collecting medication histories. And it seemed to work, not 100%, but it seemed to work at least 90% of the time, which is a good number. So the discussion, after post data collection and looking at the data, after using, statistically analyzing it, and running it under SPSS, we found that the confidence interval suggests that the true change in ratio from pre to post intervention, since 0 is not included in the interval, that there was significant evidence to show a change in one direction. The achieved power of the study is 1, which is considered high, and then the p-value of 0.0001 is less than the significant level of 0.05, indicating significant evidence of a decrease in the ratio from pre to post intervention, which is very good. It also suggests that evidence strongly suggests that implementing medication reconciliation significantly improves medication safety and enhances the quality of care provided in primary care environments. So, implication for practice. I really had to deep dive or have really look into this one. One of the implications for practice is to ensure accurate and up-to-date medication list for all patients, which is very critical. Patients understand that they need their medications to get better, but clinicians understand that how the body works. So we need to make sure that whatever information that we have as clinicians and the patient have as who the end users, that they were able to make sure in a safe manner, make sure that their medicine is up to date and we don't have any duplications or anything like that, which is one of the things that some of the patients consistently had. They had duplicated medicines, which could lead to harm. Identify and resolve discrepancies or potential medication errors through communication with clinicians. One of the things that this project highlighted was that it created a conversation between the clinicians and the nurses. Why is this patient taking this? Why is this patient still taking this? Why is the patient not on something else that could be beneficial? I.e., blood pressure medicines, medications for anxiety, stuff like that. Also, another implication for practice it's to enhance patient safety by educating patients about their medications. It's a conversation starter. When you go to reconcile medicines, you basically have to have a conversation with the patients to make sure that the patient is taking the proper medicine, they understand the side effects and the importance of actually taking the medicines. One of the things that nurses do well is teaching, and to make sure that whatever information that we wanted to convey, right there we are explaining the medications to the patients and why they're taking the medicines or why they have chosen to discontinue their medicines. And lastly is to promote teamwork. When I found that once we started using the list, the toolkit consistently, the clinicians and the nurses and the staffers, the conversation is being had. We're making sure that all the necessary professionals taking care of the patients are involved, in the sense that if there were questions that arose secondary to what was found from the documentation, it would, one, benefit the patients because it would be a questions that we would ask the clinicians, and to make sure that the patients were getting what they would need. So it was more communications between all the parties, the clinicians, the pharmacists, and the nurses. All right. Conclusion. So one of the things that I found that using a medication reconciliation toolkit in any clinical setting, especially primary care, is crucial to reducing medication errors. In this particular clinic, while challenges still exist, the clinic is actually committed to structured process change and to adopt the using the toolkit. They actually continue using it after the project, which very, very important, actually very good for the clinic, because I know just from the 2 weeks or the few weeks that information was collected, we decreased the rates of errors significantly. So the only thing that I would do differently is allow more time to collect more robust data. That's very important, because while this is a project and we are limited time constraint, the clinic has time. So I'm sure with time they would have better information about this, given that they're still continuing to use it. But when we are limited with time, we can only do what we can with what we have. But what I would do differently is just to do a retrospective study and see, looking back to see, okay, initially this is what we got, pre and post intervention, going forward, or, what other information can we deduce from using this medication reconciliation toolkit. And then lastly, this DMT project highlighted the importance of using evidence-based recommendations in clinical practice. Very important. Without evidence-based information, we would run into so many errors and so many, practices that are not practicing within the evidence that we have. But when you go into the literature and you find that and you read and you see that when you do use these tools, that they do prevent or reduce error rates, you find that, and then you introduce it into a clinical setting, you find that it actually does do what it says it's supposed to do. It helps improve patient outcomes and safety. These are my references. I'll be happy to take any questions. Thank you.